In this video, we'll do an exam review on
diabetic retinopathy, proliferative and non-proliferative. Proliferative occur due to proliferation of the blood vessels, the last stage. And whenever the retinal ischemia occur, it produces VEGF, vascular endothelial growth factor. What does it cause? The vascular endothelial growth factor causes new vascularization, production of new blood vessels to perfuse the non-perfused area. But these blood vessels are abnormal, thin, they bleed, they rupture, they bleed, fibers, the scarring occur, and that scarring decreases the vision, causes visual loss. So this is what is the fourth stage I described before others. And then three stages: stage 1, mild stage, microorganism; stage 2, moderate, microorganism and blot dot hemorrhages. In stage 3 diabetic retinopathy is 4-to-1 rule. 4 is microorganism and hemorrhages in all the 4 quadrants. 2 is the venous beading. Venous beading in at least 2 quadrants. And what's venous beading? Venous beading is irregular constrictions and dilatation in the venule, and this occurs in uncontrolled diabetes and is a bad feature. It may cause a stroke. Patient may have a stroke. So venous bleeding in 2. The last part of 4-to-1 is IRMA. That's intraretinal microvascular abnormalities in at least 1 quadrant. So these intravascular blood vessels, abnormal blood vessels, they are to perfuse the non-perfused areas. They are shunt capillaries for the non-perfusion area in diabetic retinopathy. And this is 4th stage, proliferative, I already discussed, due to retinal ischemia producing VEGF that causes neovascularization. Then fluorescent angiography determines the degree of ischemia in diabetic retinopathy. So I already explained what ischemic retina produces, VEGF, that causes increased permeability, swelling, edema, and increase in visual loss. Then how do we control the diabetic retinopathy? By controlling the blood sugar, blood pressure, and cholesterol. The A1C, that is 5, 6, 7, 8. If it's 5, then its blood sugar is 97 milligram per 100 ml. It's 6, 126. It's 7, is 1. So between 5 and 6, 6 and 7, and 7 and 8, there is a difference of 30 milligrams, right, of blood sugar. And between 5 and 6 and 6 and 7, there are 10 points between 5 and 6. So at 5.1, the blood sugar will be 100. Similarly, you go up and you can calculate how much is the blood sugar if it's 5.9. So it should be 123. So glycemic control, then we have insulin, how much insulin is given in different patients at different blood sugar level, what type of insulins are. This is what cardoline is as the plateau, and this is the regular one, which is clear. And to those who are resistant to insulin, their dose is exceptionally more, and it's 1 to 2 units per kg per day. In a obese, overweight patient may be given 200 to 300 units a day. But normally, you don't give an insulin up to 140. Because how much 1 unit of insulin reduces the blood sugar? 1 unit of insulin reduces about 25 to 30 milligram of blood sugar. So if the blood sugar is 170, the patient will be given 1 unit. For 200, the patient will be given 2 units of insulin. So the 300, so minus 150, it's 150 extra, so 6 units for the 300. And if the patient has 400, then minus 150, it's 250. So that's 10 units are given. Then how many patients develop retinopathy? 25% in 5 years and almost 100% in 20 years they develop retinopathy. And most common complication is retinal detachment and visual loss,
vitreous hemorrhages, retinal detachment, and glaucoma.
And the drug treatment, of course, control of diabetes, and anti-VEGF drug, anti-vascular endothelial growth factor drug. They are monoclonol antibodies. Examples are aflibercept and ranibizumab. It may be given intravitreously. So what are the effects of anti-VEGF drug? That they regresses the neovascularization, regresses the macular edema, and decreases the visual loss. Other treatment is laser that also decreases neovascularization, decreases edema, clears hemorrhage, and decreases the visual loss. So these are the features here with the laser surgery treatment, with the anti-VEGF treatment for diabetic retinopathy. But this laser treatment is not effective in advanced cases of diabetic retinopathy. So what to do with severe maculopathy? Steroid eye implants are given in severe diabetic maculopathy when laser doesn't work. And eye surgery to remove any clot, scar tissues, vitrectomy is also helpful. So which drug prevents or slows down the diabetic retinopathy? It's metformin. Metformin slows down the diabetic retinopathy. It's a biguanide. And how does it act? It increases the activity of AMP kinase that inhibits the gluconeogenesis, because gluconeogenesis increases the blood sugar. So once it stimulates the AMP kinase that inhibits gluconeogenesis. Metformin decreases the GI absorption of glucose. Metformin decreases glucagon production. Glucagon is hyperglycemic by increasing cyclic AMP. Insulin is hypoglycemic. Glucagon is hyperglycemic. Metformin also increases the peripheral utilization of glucose. It increases the entry of glucose into the cell, but it does not have an effect on pancreas to increase the insulin production. And how much metformin reduces the blood sugar? It lowers the A1C by 1.5% at maximum dose. So it's 7, it brings it to 5.5.
Diabetic retinopathy. How common is the blindness in diabetes? Diabetes is the leading cause of blindness, and it's about 25 times more common in diabetics than in non-diabetics. So the legally blind are 25 times more in diabetics, and retinopathy occurs in almost all cases. What's the best predictor of the development of retinopathy? The duration of diabetes and the control of hyperglycemia. Glycemic and blood pressure control delays the retinopathy. How many people develop retinopathy and when? Almost all patients with non-proliferative diabetes mellitus develop retinopathy in 20 years and 25% in 5 years.